Lateral ankle instability is a very, very common clinical topic. We will not go into a lot of basics. I want to take you through the current concepts and what's new. A lot of anatomical studies are erupting these days, and they change our mind about causes of lateral ankle instability, repair, why we end by chronic instability even with repair, and we'll get you through basically the updates only. So you need to understand the domino effect. So a lot of studies is going on now, from especially from Netherlands. It's a very good uh, anatomical department there, and they see that the lateral ankle injuries is not just a tendon injury or a ligament injury. It's actually a domino effect. So it starts with one ligament injury, then it goes with abnormal positioning of the TLS inside the morts, and this ends by a problem with on the medial side, a problem higher on the syndesmosis, and may end even a problem more distal in the subtalar joint. So why it's important? It's very common. So 3 to 5% of all the visits to the UK ED is coming from ankle sprains. 10% of all the injuries and regular visits in the US, you can see that basically 40% of ankle sprains will continue to experience pain and recurrent instability. This is because the ankle sprains are common and because we under-treating them or underestimating them. So we treat ankle sprains very lightly. This end, but as you can see, 40% of these patients will coming back with an experience of pain and instability, and 70% of them will end by a chronic instability, which will end by them into a OA. 1 in 3 of them will develop a re-injury on the same day, especially in the elite athletes, and repeated injury will end by a post-traumatic osteoarthritis, as we all know. Please remember, it's not always a mechanical instability. Sometimes it's a functional instability when everything is okay clinically and radiologically, but your patient is still complaining of giving way. 11% of injuries in the prime league. So it's a very common topic, and in all the sports clinics, it causes more than 12,000 days lost from the elite athletes, and above 2,000 matches lost. 9% of this get a re-injury in the same season, and 34% of them get a repeated sprain within 3 days. So actually, the money goes with that financial burden is about $250 million. So what's new in the anatomy? We all know the anatomy. We know there is an ATFL, CFL, BTFL, and higher there is a syndesmosis between EITFL, interosseous, and BITFL. And as we spoken in the last talk about the dynamic stabilizers of peroneal tendons. Well, you need to know that the new eruption of anatomy is showing that when they went in and anatomically analyzed the lateral ligament complex, it's not that simple, just ATFL. This ATFL has a lot of anatomical variations. Could be 1 ligament, could be 2 ligaments, could be 3 ligaments, and commonly it's 3 ligaments. And they come to speak about the dogma effect or the conjoined tendon when they see that the inferior bundle of the ATFL is just joined the CFL. So if you have an injury to both of them, you may go and repair the ATFL, but you missed that you didn't repair the CFL, and this CFL is associated with the inferior bundle of ATFL, and this will be one of the commonest cause of you having a chronic instability in your patients after repair. The more important to me is this, when you see the 2 bundles of the ATFL, superior and inferior, and when they go in more detailed anatomy, they found that this superior bundle is actually intra-articular. So it is inside the joint. So it has some synovial fluid there, and getting this to heal after repair is not happening as we're treating an ACL. And this is another cause of having a chronic instability after a prostome repair. So if you are not meticulous enough to get the superior bundle and the inferior bundle repaired, each one alone, and CFL repaired, either you will be repairing all this bulk and missing the inferior with the CFL, or you'll be repairing this bulk and missing this part, which is intra-articular and very rare to get healed, and it will be causing a chronic instability later on. So from this point of anatomy, I need you to remember that ATFL is 2 bundles, superior and inferior. The superior is intra-articular, and because it's intra-articular, healing will be very poor because of the synovial fluid. And if you will repair, you need to repair every bundle separately. The second point is inferior bundle is not separate. It has a conjoined tendon with the CFL. So you need to be sure that this area is very nicely repaired. Otherwise, you will be losing like 70% of the stabilizer of the lateral ankle, and this will end by the ankle into chronic instability. Again, the idea of the conjoint tendon. So Mikey is very good anatomist in Netherlands, and he's working around the ankle, getting us every day an update on the anatomy. So contributing factors is not only a mechanical problem of the lateral ligament, but definitely the malalignment. Cavus is one of the commonest causes. Poor neuromuscular control, especially in people who are malnourished, people who are very lazy and not doing any sports or physical activities. Patient who lost the proprioception and with a proprioceptive deficit, you cannot easily stabilize your ankle. Your brain has lost the map of the ankle, so he doesn't understand. Your brain doesn't understand what's the position of the ankle when he asks this muscle to fire, when he asks the other muscle to relax, and this will end by a lot of stresses on your ankle, which may end by ankle sprain. Very common associations. So we always just concentrate on the lateral ankle sprain as is the commonest, but we miss that this is sometimes associated with higher sprain or syndesmotic injury. Very commonly associated with osteochondral injuries, especially if it's repeated, and commonly associated with peroneal tendon rupture, as they are sharing the same mechanism of injury, which is sudden inversion, and very commonly to be associated with deltoid injury based on the domino effect we spoken about at the first slide. History, you will find this patient definitely have a history of trauma or inversion injury. Sometimes it's very subtle, just he has been trapped by something. His foot went into like a pothole or something, and since that he started feeling some giving way. He just manages with some pain management, but his ankle is not normal. This patient you need to be very careful about, because they have a good pain threshold, but they have a big problem to the ankle. Definitely the pain and tenderness will be lateral to the ankle. Patient will come commonly with mechanical symptoms like clicking, giving way, sensation of insecurity, ankle swelling and subluxation in late stages. When you examine, you need to again have a very thorough examination. See the patient who is coming into your clinic, stand the patient, have a look on the malalignment 360 degrees around the ankle, walk the patient and look for any dynamic instability or deformity. Please put your hand on lateral mal, the three ligaments, ATFL, CFL, BTFL, but don't forget the association. So put your hand on the navicular, put your hand on the deltoid and base of fifth metatarsal. Feel for any joint tenderness, and any joint line tenderness cannot be explained by just the lateral ankle sprain. This means there is an associated osteochondral injury. Please check for sural nerve. It's not uncommon to have a sural nerve neuropraxia with a significant lateral ankle injury. So again, you can see the global instability. Anterior drawer is absolutely gone, and varus inversion is gone as well. So when you go to imaging, so it's a very common trap for all of us, because simple supine X-ray will not show you anything unless like an avulsion fracture, like something like a big osteochondral injury, which is very rare to happen. But your X-ray minimally needs to be a weight-bearing X-ray and comparable, so both sides weight-bearing X-ray. And if you want to be more meticulous and catch the diagnosis by X-ray, you need to go for a stress view, either stressing into inversion or stressing into internal rotation. Definitely it's very painful, and we leave that to intraoperative under MUA. But if we speak about X-ray, for X-ray to be a tool to say if the patient has an ankle sprain or not, you need to have minimally weight-bearing X-rays both sides, or to have stress views. When you stress an ankle sprain, which all the ligaments are gone, you can easily spot that the talus is tilted inside the mortise, and the lateral ankle is opening. And when you go to the anterior drawer, you can easily see that you can easily draw the talus underneath the tibial plafond, and this will be the picture if patient allows you to do such a stress view, which is very rare to happen, but we get these views intraoperative. Ultrasound, very nice. Easy one, can do a lot of institutes now do it in the clinics. You have an ultrasound course or something, and you can easily get a probe in your hand and test and have a look, see if the ligaments are gone or not, if the tendons are injured or not. But again, it's very, very operator dependent. MRI scan is an investigation of a choice, and I've shown you here the normal before the abnormal. So if you go, you need to be very clear. So to see the ATFL, you have to see the whole fibula feeling the lateral gutter. If you see like that, so you start feeling this is not the full gutter filled with the fibula. This is the BTFL, not the ATFL. CFL is very clear, and you can spot it in all the images. And definitely, if you go to axial cuts, you can easily spot the ATFL between the tip of the distal of the lateral malleolus and early neck of the talus. You can see the injury, and you can easily spot this fluid signal here, and a lot of grading. But to be honest, is all of not clinically or practically applied. We easily spot it as minimal instability, significant instability, or gross instability. But if you have a very good eyes and you have a lot of MRI scan reviewed before, you can spot that here is just some thinning of the tendons. Of the ligament. So the ligament is still intact, but very thin, and there is fluid signal around. This is what we call grade 1. Now the tendon becomes thickened. So this is like a recurrent injury, but the tendon is still in continuity, and definitely grade 3 when the tendon is the ligament is completely gone. So grade 1 ligament is just thinned, and there's a fluid signal around. This means a minimal injury. Grade 2, when the ligament is thickened, means it's a recurrent injury, but still in continuity. And grade 3, the ligament has gone completely, and you cannot see any continuity. For the CFL, nearly the same. So this is normal. There's a disc here, and the tendon is still intact. Now it starts to be thinned, and the fluid signal inside, then now it's completely gone with no continuity anymore. You need to look into the associations, and I'm keeping stressing on the associations from time to time. So osteochondral injuries, medial side stress injuries or stress fractures at the medial body of the talus and the medial malleolus, deltoid injury or avulsion, and tendon injury, peroneal tendon injuries. Grading, as you can see, very simple. It's either incomplete, complete, or complete with CFL. When you go from up down, every time the stability is the instability increases, and your need for more operative intervention increases. So going from up down, instability is more, injury is more aggressive, and treatment should be more aggressive with more operative intervention. So either starting with incomplete injury, which you see every day in your clinic, minimal swelling and tenderness, you both your hand is tender, but some fullness there, but still the ankle is stable, and still the patient doesn't have mechanical symptoms. So what you go for that is just rest this ankle for 2 weeks in a boot, and send the patient for proper physiotherapy with proprioception and balance exercises. Complete ATFL injury, but the CFL is still intact. The patient will be definitely more symptomatic with more swelling, more tenderness, some loss of function. Anterior drawer is positive, but the varus tilt or varus inversion is still negative. And this patient will need a bit more aggressive treatment. So if the patient is active, young age, doing a lot of activities, depends a lot on ankle, I will advise you to operate on this patient. If the patient is minimally moving, just normal daily activities, not that active, not doing sports or regular exercise, you can continue with non-operative treatment, but keep an eye on him for follow-up. But definitely grade 3, when the ATFL and CFL is both gone, ankle become unstable. This patient, if you leave, will end by osteochondral injury if he or she doesn't have at the moment, and will end by post-traumatic arthritis. So this patient which you need to operate on. So non-operative management, which we will use in grade 1 and grade 2, which is incomplete ATFL or complete ATFL with intact CFL, it will be rise and splinting for acute injuries for at least 2 weeks. Then both in a functional ankle brace, because you need to have a dorsiflexion, plantar flexion range. You don't allow the patient to evert or invert, but he has to move the ankle. Otherwise, will be a lot of adhesions, and he will not be happy later on. Proper pain management to allow him to go for exercise and physiotherapy as early as possible. Functional rehab with proprioceptive and balance exercise, and at least 3 to 6 months. At least 3 to 6 months before you can judge has the conservative or physiotherapy done a job for this man or not. Return to activity depends between 3 to 6 months. That's why this option is not a valid option for the athlete people. What if it's complete ATFL without CFL, but the patient is very active and I need to do something to get him back to sports and activity early, or it is a complete rupture of ATFL and CFL? What we will do depends on what's in your hand. A lot of questions before we decide what operation we will be using. But the most important, again, you need to get it right first time. Will I repair or not? Definitely I will repair. So open or arthroscopic evidence doesn't show a big difference, except for minimal infection, better infection, less infection and better wound problems with arthroscopic, which is very expected. Well, anatomically or non-anatomically, I will show you the evidence. Again, anatomical is our first choice. If there is no option for anatomical because the tendon has completely gone, or pathological, or I have anything stopping me doing an anatomical repair, I will go for non-anatomical. Shall I individual ligament or one bulk? We spoke about this when we explained the new era of anatomy. We need to understand about the superior and inferior bundle of ATFL, conjoined tendon between the inferior bundle and the calcaneofibular. Will I repair the retinaculum or not, which is the gold modification? In my hand, I repair the retinaculum. Evidence says it doesn't make a big mechanical advantage. Will we use an internal brace or not? Internal brace is an artificial ligament. It gives you the option of securing your repair, getting a more stable ankle, but on the other side, if you don't do it rightly, will end by a very tight ankle and may end by impingement and stiffness. So we keep the internal brace for the people with hyperlaxity or very gross instability. Will I do a diagnostic arthroscopy before my repair or not? I do routine diagnostic arthroscopy before my repairs, but very short diagnostic arthroscopy under very low pressure, not allow the tissues to swell and disturb my planes when I go for repair. Because if you put it under high pressure or you keep scoping the ankle for a good 15-20 minutes, you will end by very swelling planes of tissues, and it's so difficult not only to identify the bundles but even to identify the ligament itself. So my advice to you, you can do a diagnostic arthroscopy before every prostum gold repair, but go very quickly, very low pressure, and be directed to catch if there is an osteochondral injury or not. Some people do it after the repair. I don't advise you to do that because after the repair, the ankle will be very tight. So you use the ligament injury and the instability of the ankle to give you a bit of space to do a quick scope. But if you do the scope to avoid the swelling of the planes and soft tissues and keep the scope after the repair, your ankle will be very tight and you will struggle to do the scope. So what the evidence says, long-term results. So for prostum gold repair is the gold standard. I'm not aware of any center in the UK or even in a few countries around the world that use anything else. Prostum repair is the perfect one. Anatomical does a good job, always feasible in most of the patients. As you can see, we have results up to 26 years, which is showing about 90% good to excellent results. As I told you, when you compare arthroscopic to open, it's nearly the same functional outcome, same anatomical outcome. It's only less infection and wound problems with arthroscopic, which is expected. If you look into will we internally brace or not, there is a significant better outcome in early rehab and return to pre-injury level with brace, internal brace, but you have to do it properly. If you don't do it properly, you will get the harm will outweigh the benefit. If you compare prostum versus prostum gold, as I told you, as far as I know, all the surgeons I've worked with during my fellowship, during my consultancy, I haven't seen anyone doing prostum only without gold, because you just repair the retinaculum outside, and even if the evidence says it doesn't give any biomechanical differences, I don't think it causes any harm. So I do gold modification to every prostum I do. So what's my approach in this? So if I have a patient acute first-time injury, careful examination, ensure there is no mechanical symptoms. If the patient is not athlete or grossly unstable, I will put him or her in a boot for 2 weeks with rise and rehabilitation from 2 weeks onward for at least 6 to 12 weeks with physio. Then I see at 6 weeks point and plan when I will allow him or her to go back to normal activities. If patient is athlete, I will go directly for diagnostic scope and Broston Gold. If the patient is grossly unstable, I will add an internal brace. What if it's a chronic injury or the patient is still symptomatic or the conservative treatment has failed? If the patient have a ligamentous hyperlaxity, so Batten score 4 plus, so I go for scope, Broston Gold, and internal brace. If the patient has a normal Batten score, it means 4 or minus, I'll go for diagnostic scope and Broston Gold without internal brace. Thank you so much.